Class, shall we start?
Okay, sir. Good evening, everyone. Welcome to the second day of our six-day faculty development program on advanced artificial intelligence and machine learning techniques for medical imaging application. We are delighted to have with us our resource person, Dr. Dinal Shashankarlayam. He is a research associate in the Division of MR Research, Department of Radiology at Johns Hopkins University School of Medicine. His research mainly focuses on developing advanced MRI methods to study brain blood flow, perfusions, and vascular reserve. His work has important application in stroke, brain tumors, and vascular cognitive impairment. During his PhD at IIT Delhi, he created MRI methods to study vascular integrity in brain tumors. And these techniques are now being used in leading institutes like NIMHANS Bangalore, Fortis Memorial Research Institute, Gurukulam, and the University of Pennsylvania. Along with his research, he also contributes the scientific community by reviewing papers for the top journals and serving as a trainee editorial fellow at the Journal of Magnetic Resonance Imaging. We are truly fortunate to have him here to share his expertise and experience with us. With great pleasure, let us welcome Dr. Dinal Sachi Sankarlayan to begin today's evening session.
Great, thank you for the wonderful opportunity. Let me share my screen. I think I don't have the permission to share my screen.
Okay, I will.
Yeah, I think it's working now. Let me see. Can you see the screen now?
Yes, it's visible.
Is it in the presenter mode now?
Yeah.
Perfect, right? And you can see it changing, right?
Yes, it's working.
Great, great. Thank you so much for this opportunity. So before starting, I wanted to know how many of you are kind of familiar with brain, familiar with any type of imaging modality, say MRI or CT or whatever it is, PET. I just wanted to have a brief idea of where you kind of stand, and that would be helpful for me to kind of take it forward. So can we have a poll or something, um, so that people can just say, just a yes if they have some background on brain imaging. Is it possible? Are we on the same page?
Okay. I think in the chat box, someone may reply to
Oh
you.
yeah, it would be great if people have any experience, just put a yes in the chat box. That would be great. I mean, I'll have an idea on where we stand before we start. No response. No response. Okay. I presume. Okay. Somebody is texting. No. Okay. I presume you are quite naive to brain structure of brain. Maybe you had a preliminary education during your early phases of when maybe in the 10th standard, 12th standard. People from biomedical engineering background or biotechnology might have some experience during their early undergrad or postgrad days. Keeping that in mind, so today I'm going to talk a bit about quantitative neuroimaging, which means we are trying to quantify certain things from brain images. Maybe it is, how the brain functions, how the blood receives enough supplies of nutrients, say, maybe a pool of blood, a set of, oxygen molecules, how it reaches the brain. and can we extract some of those physiological informations or functional informations from that, and how statistics can aid in routine clinical diagnosis, if we can use these numbers for prediction or treatment monitoring, or any other aspects of the clinic that radiologists are interested in. I'll show you some of the cases that I personally dealt with, or some of the recent advances that's been there in the literature, to give you a brief idea about what's going on in the field. So the main agenda of this talk is not to give you a brief or a detailed overview of different AI or machine learning techniques, or maybe how a convolutional neural network works, or classical machine learning works. No, I'm not going to go deep into that. My intention is to give you an idea of what's going in the field of neuroimaging, particularly in a research settings, or how it is getting translated into clinics. And I'll share you some of the open source data sets that maybe you can use in your own projects, or you can play around with if you find it very hard to get some clinical data for your own research. So that I think that sets the stage of what to expect from my talk today. So let's kind of start with simple steps. Let's talk about human brain first. We know that human brain is a very complex organ system. This has a very uh, multi-dimensional approach on how we live every day. Maybe it works combinedly with the cardiovascular system and the pulmonary system. The cardiovascular system helps to pump the blood into the brain. Respiratory system aids in supplying nutrients, and brain has the sophisticated different areas, as I shown here in this diagram, which kind of act together in a different ways to make us what we are, right? What we think about, what we do. Suppose if we like you guys are attending my talk, and if you want to respond to something, if you look at this chart, you might be, first your sensory association area will work on what I'm talking about. You try to understand what I'm talking about, trying to sense that. Your auditory area might process the information. It might take into some of your association areas where it try to link with some of the previous informations that you had. And if you don't agree with what I'm talking about, you might have to react. Then some other areas, cerebellum might come into picture, which is because it is kind of help us in coordination and other locomotive movements. So overall, this is a combination of approach that brain works to make feel what we feel it is. So that is a very interesting part. So to study this brain, we really have to look at it in a micro scale and kind of build it up from there. You cannot kind of have a whole global picture and say that the whole brain is going to work like this, or the particular structure is going to work this. It's very hard to say. So whenever we talk about any of this neuroscience or neuroimaging research, we always start with very simple steps, or very simple discrete steps, different regions, how it works. And if we can extract some of the physiological informations or some of the functional informations from those simple regions and kind of translate into a bigger picture. So that's the idea. Uh, Basically, if you look at the brain we divide it into four regions. Primarily it is temporal. If I can show, this is a frontal region, which is mostly efficient in our day-to-day life. We have the parietal regions on the right sideways. We have an occipital lobe on the anterior side, which is more useful in visual processing and auditory processing. And we then have a cerebellum, which is kind of coordinating all these locomotive purposes. Now, if I take a kind of a cross section of this brain, we could find two different types of tissue. Normally, we call it gray matter and white matter, just because gray matter looks gray and white matter looks white, as it is. Very simple to understand. The reason is that white matter is combination of a lot of axons and neurons, which neurons are the basic structure that is responsible for information processing. It has the different parts, starting from dendrites to the axon terminals. Information flow as electrical signals, action potentials, and those things that I presume you already might have exposure to. Uh, all these neural structures would need a lot of blood supply. The blood supply is the source of fuel. It is the oil that feeds. It's simply, we can have an analogous to any machine, maybe a car. We have gas or diesel that pumps up, and the piston and every other part works in tandem to move a car. Similarly, it's the blood that gives nutrients and oxygens and all other steps to the brain, which is mostly concentrated in this gray matter region, which says that we ensure. So gray matter tells the white matter that we ensure that we will give you enough food and nutrients and blood, whatever you want. Make sure you work properly to have all the coordinations to work in tandem. That's how they coexist, and we have this set of regions called ventricles, which is more or less, it comprises of cerebrospinal fluid. You might have heard about cerebrospinal fluid, which is primarily helps in keeping a cushion of the head, which helps uh, brain from external shocks or action. One of the other use of this cerebrospinal fluid in the ventricle space is to clear the waste. Once the brain processes a lot of information, we have a lot of carbon dioxide, and there might be some waste that have to be removed from the brain, which is kind of taken through ventricles and CSF, take it through a different system called the glymphatic system that takes the waste out of the brain uh, through the excretory domain where we take it out. Now, for a brain to function properly, it basically needs three layers, which is not discrete, which acts very tandem. One is, as I said, a vascular network which takes the blood from heart or lungs to the brain. Heart pumps it very, very hard, and it takes into the brain through a layer of arteries, feed all the brain regions, then drain into a set of veins, which I'll show in a couple of minutes. Next is the metabolic response. Once this a pool of blood reaches a particular tissue of interest, say some of the regions of the gray matter, or say some nucleus regions, hippocampus, see, that is a major source of information processing in our brain. So once it reaches there, the brain knows that it gets some nutrients from it, and it knows which hormones to trigger, what to do if you are kind of anxious, maybe or it might trigger some of the dopamine or norepinephrine or something like that, so some of those neuromodulator. So that is a different set of metabolic response that brain does in tandem with other parts, and make sure that we react to it, or our homeostasis is properly aligned with it. Next is the neural circuit, which, as I said, works in tandem with cerebellum to have a proper response from our side. So all three of this phenomenon work in tandem together. We cannot exclude one of the other, and make the brain such a beautiful organ to work with. Now, if you look at the vascular network, what happens is you see this large arteries that is going into the skull, which is called the internal carotid arteries, that takes the blood into the brain. And there is a region here which is called the circle of Willis. It reaches there, and it then distributes into small branches, which is called arterioles. And these arterioles take the blood into deep tissue regions. Once it reaches the deep tissue regions, as I said, it consumes the oxygen from it, which we call it in different terms. Some people say, it is the oxygen extraction fraction that works out, or some people say it is the metabolic rate of oxygen that works out. Whichever it is, the brain consumes that that oxygen reserve and processes it. The waste clearance, waste materials, or the remaining carbon dioxide are pushed into the vein structure that is shown. So if you look at it, this is the other way, right? The arteries have a bigger arteries that is branching out into the brain, branching out into the small regions. And if you look at the other perspective, all the small regions again collects brain from the brain regions, which is called venules, and this then merges into bigger arteries. Number one mentioned here, it is superior sagittal sinus, which is one of the major feeding artery, or sorry, vein from the major draining vein from the brain. So if you look at the direction, the blood flow goes here. Maybe I should use a pointer here. So if you look at here, this kind of go up uh, in direction, and here it kind of comes down in direction. So you have the superior sagittal sinus here, you have kind of a transverse sinuses here, and it drains through the basilar veins that we have. So that is the overall process of vascular networks. And now, if we go one more step ahead, we have something called structural and functional connectivity, which basically means that different regions of brain work together. And there is some, even if you sit idle, if you don't do anything, there are some parts of the brain that is working, right? We call it default mode network, which is, as the name suggests, is a default mode. So there are different parts of the brain that communicates together as a structural, functional, or a communication dynamics, which we could extract those information using some of the sophisticated technologies or advanced quantitative technologies called functional MRI, which I'll touch upon later. So before getting there, I just wanted to give you a brief introduction that this thing exists. So that is so once so you look at it, if you look at it, so all of this brain structure or the communication or the functional dynamics, you could really imagine this as graphical networks. And that is the beauty of quantitative imaging or all this data analytics or statistical or machine learning, whatever you call it. Is these all of this number-based techniques would help us to understand or to optimize how this properly functions. And once we have a norm, if you have a norm of a group of people, how it works, then it is quite easy to find an anomaly or an abnormality. Suppose, let us take the middle figure here in the communication dynamics. Suppose if you know that there are, say, 8 or 9 nodes as shown here that works in tandem for us to have a proper communication. Once we have a global atlas that shows this communication domain, we could, if somebody with, say, an non-verbal autism who cannot have a communication, who lacks communication ability comes to a clinic, if you have a standard norm or standard atlas, it is very easy, right? We could really compute this graphical networks, and we can say, oh yeah, this person has this, maybe this path broken, maybe their somatosensory network is not talking to their default mode network or something like that. Then we can say that the correlation between these two regions are very poor. That is the reason this is happening, and maybe then we have enormous opportunities for diagnosis or for maybe even drug discovery. Once you know that this pathway is broken, you can really dive deep into that and say that this is what it is broken, and we can really work on this. We can understand what is going wrong here. So that is the main idea of all of this neuroimaging research that we do. We try to create a norm first. We try to create an atlas first, and we always try to compare this, whatever abnormality or clinical situation that we see. We try to compare that with the global atlas or global standard or norm, what we call norm, which is eventually a mean of a global population. Or we might take 1,000 or 2,000 or maybe 10,000 people and do some statistical sophisticated analysis, and we say that though overall we had a look at the decent number of people, and we say that this is how it works. And if something is going wrong, we could really compare it with it, and maybe we can take it from there. It's always the small steps matters. uh, Now, uh, let's talk about imaging the brain, right? So there are different techniques of imaging modality, maybe from ultrasound to MRI or maybe PET. Uh, Different instruments have their own niche areas of identifications. Some people use it due to clinical constraints. Some people use it, in some cases you just need X-ray, then you don't need to go for a sophisticated MRI scan. Let's start with X-ray first. If you look at the head of an X-ray, you would see something like this. This is basically a bone. X-ray is something like having a brighter torch, right? I mean, if you have a brighter torch towards uh, say a coconut tree in the night, you would see the shadow of that. X-ray is something similar. You see only the hard tissue bone structures, and the hollow brain structure is not quite evident here. So then, what else can we do? Maybe we could go for a CT. CT is nothing but MRI, sorry, X-ray, which is X-ray has torching at single direction. In CD, we would torch at different directions. We will kind of revolve around and torch from different dimensions, and you kind of reconstruct it to get a better picture. It gives a better contrast to X-ray. Still in clinics, people use CT for brain imaging in stock applications. Couple of reasons. So one is the time constraint. Stock is, very time limited. You have to manage stock patients in a given time of window. So it's very hard to get an MRI scanner. Accessibility issues, timing issues. Even if you get a scanner, the scan might take long, might not have established protocols. It's still an upcoming domain. So that's about CT. It gives us a little bit of soft tissues, but doesn't really tell us, different structures. You could see some of there's a straight sinus here, some of the lymphatic space here. It's not really clear, but we need some more information. We need to quantify things. We need to talk about things in numbers, right? So next is a PET scan, which gives us PET is basically a tracer, uh, that goes in, and wherever there is high metabolism, it gives a signal. So if you look at PET, yes, you could see all this soft tissue contrast. PET is still one of the gold standards for measuring different metabolic responses. That's one of the gold standard thing that's still in the market, but the thing is, it's non-invasive, and you cannot do CT and PET very frequently. It's a need, but still, it's invasive. It causes harm. The next is MRI. So that's the beauty of MRI. You see inside the MRI, you could see different tissue contrast. You can really play around with this contrast. You want to make this bright things dark, you can do it. You want to make it this dark thing bright, you can do it. If you want to just look at the blood vessels, you can do it. If you want to just look at some small tissue regions very brightly, you can do it. So that's the beauty of MRI. You could play with all this tissue contrast, and that's what we do. We try to play with this tissue contrast, and we try to make out some of the informations from it, and we try to see, if this is useful for the clinic. And if it is useful, yeah, then it's really wonderful. The problem with the brain is you cannot really dig inside the brain, like take a biopsy every time, or kind of have a cut and look at it. It's not possible for the brain. Maybe you can look at it for some other parts, but brain, no way. I mean, it's very hard to play around. So that's where MRI comes to the picture. We really need to look at something that's really interesting. That gives us different perspectives of information. Now, let me give you a brief explanation about the underlying principles in MRI. It's a very vast topic. I could talk days and weeks about MRI. It's still a different code of its own, so I don't want to overwhelm you with all of those informations. But I'll give you just a brief introduction of MRI in just 2 minutes. This is a YouTube video that I found. I thought this is really helpful to kind of have just a brief outright. I hope the audio is correct. Is the audio reaching there from the YouTube video? Previously, I had some issue.
Yeah, I think Dinil, it's not playing, like the audio is not playing. Just try once.
That is, it's still not there. Still not there.
Yeah, for me, it's not. Yeah, it's not. It's not for someone else. It's
I
audible.
don't know what is the problem here.
Can
When I
you
tested,
settings or something?
let's see. It's not playing now. How about now? No,
Still no?
still no.
No. For me,
Okay.
yes, I don't know.
I mean, it should work similar to everyone, right? So let's keep it. So that's just a basic of MRI, but I would try to explain it here. So basically, MRI works on magnetic fields. We have a main magnetic field, uh, which we always call as B0. We call it in the range of Teslas. Typically, if you have ever had an MRI scan, we say it in 1.5 or 3 Tesla are the standard uh, clinical scanner, the strength of the standard clinical scanners. What happens is the basic idea is that every proton or every proton in the brain or in the human body has three properties, which is mass, spin, and charge. So mass and spin will give you a magnetic field, and mass and charge will give you a magnetic field. So this, when placed in an external magnetic field, will align towards B, making an angle, say, between the hash line and the black line, and kind of precess. So there are two motions. M is the magnetic field of a proton, which I'll come in a minute where it is. This kind of rotate its own axis, and once it is placed in a main magnetic field, it not only rotate in its own axis, it presses in the main magnetic field axis. So it is a two-dimensional spiral rotations. Now we modify this M, which is basically signal from water. Our body consists of around 80% water, 70% water, and each water molecule has an H plus, right? So we have a lot of protons, and M constitutes a bunch of protons together. Suppose if you take a voxel, it has a bunch of protons, and when it is placed in an external magnetic field, it produces a net magnetization vector, right, in this direction that is parallel to B, which is the main magnetic field. It's not standing still, right? It's not standing still just because it has three properties, as I said: mass, charge, and spin. This will constitute some angular momentum, and we write the equations of that angular momentum, the motion, and we derive different image contrast from that. What we try to do is we tilt this vector M towards a different plane. Suppose the B is in Z plane, Z axis, we have X, Y, Z axis. Suppose the B is in Z axis, we have the XY plane here, as shown here. This is the initial magnetic field aligned with B here. And we apply an external low energy radio frequency pulse, which has the same frequency of M, which induces a resonance. And as a result of that resonance, this M will tilt into the XY plane, where in the XY plane, we have the receiver. Ideally, in the M, if it is in the M direction, we don't get any signal. The receiver is in the XY plane, and we tilt it. Once it is tilted, we look at two things. Once it is tilted to the XY plane, it goes back to the Z plane, because we have higher magnetic field here, the energy dissipates in the XY plane, gains in the Z plane, and it goes back, and it has a loop or a trajectory like this, which if you travel with this trajectory, say you are looking from outside and you see the spiral, and if you travel with this trajectory in the same plane of this trajectory in the same axis, you would see something like this, right? The magnitude slowly goes up in this direction, which is called mz, which means the energy is gained here, and in this plane it is going down. So we have basically two kind of relaxations. One is a gain of magnetization, and the other is loss of magnetization, which normally we say this is a longitudinal relaxation and this is a transverse relaxation. Now we look at it, we have a time constant for different tissues, which we call as T1 and T2. If you talk about MRI domain, people generally say T1 and T2, based on which we extract informations. And this is the T1 relaxation, and this is the T2 relaxation, that where the signal goes down, and which is an exponential decay with a relaxation constant T2. And as I said, different tissues has different relaxation rate, and there are some timing parameters, which is, I don't want to get into the details. We kind of modify this. TR is called a repetition time, and T is called an echo time, and we can modulate this time to generate whatever contrast that we need. That's what I mean. If you acquire the signal at this TR, the contrast between blue and red curve is different. If it is here, it is different. If it is here, it is different. Same with, T2. So you could really play around with it. You can even play with both the times. To give you a clinical example, this is a different contrast that I said. See, this is a typical T1 weighted image where you see gray matter as gray and white matter as white. And you have some nice tumor region here. I shouldn't use the term nice, but though it's look nice, it has some of this abnormality here. Now, this is a T2 weighted image. And the contrast is, if you look at here, the tumor region is highly highlighted here. The fluid regions are highly highlighted, and the ventricle is also highlighted. So you don't know really, which is a real fluid that you're looking for. Where you have another manipulation, which is called FLAIR, which is a short for fluid attenuated inversion recovery, where what we try to do is we adjust the timing, modulate it such that you nullify the signal from this ventricle space. So basically the difference between this and this is we just nullify the signal here and you get a nice tumor regions. This is what we call edema, which is basically any swelling that you get, any swelling, any water component that you get from any wound is edema, which is basically water. And that always fills up, any abnormal tissue, which is part of our inflammatory response. So you have tissue regions and all this edematic regions. Now, the next thing, there is another sophisticated thing called diffusion, which says that how freely diffusible it is. If it is dark, it says that it is not much diffusible. If it is white, it says that it is a little bit diffusible. So you can really compare with healthy tissue. This is a white matter, and you could see, how this is working with white matter, and so on. These are some other. This is a blood flow. This says how much amount of blood flow in milliliter per 100 gram of tissue per minute is flowing into these regions. So if you use kind of this ASL, which is called arterial spin labeling, and the diffusion, you could really see, this is complementing. You could see the high blood flow here. You could see the diffusion structure here. Maybe a necrotic region here where we don't have any high diffusion or high blood flow. So these are ways to look at it. Different parameter images. That gives you different informations on on this particular case. It's a brain tumor, and the surgeons can kind of plan the surgery. Like these much of areas have a bigger impact. Then you don't have to go that region. You just have to focus this. So that's all few things pre-surgery. And you could really do some quantitative grading or some other information, which I'll show in a moment. That's another part of the story. So ideally, that what I'm trying to convey is that with MRI you can have all the sophisticated contrast, and that gives you enormous information from multiple dimensions. And You can really play around with it for the clinical need that you have. Now, let's go to typical examples. Let me start with glioma. Glioma is one that kind of a brain tumor which has very low survival rate, and this constitute of almost around 80% of the brain tumors. And the important part is, I mean, I've seen patients with glioma uh, from 6 or 7 years of age to 70, 80 years of age. One thing is quite consistent across is they find it very hard to survive, particularly if it is a high grade glioma. It is very hard to find it in the low grade space. That's one of the preliminary challenges. You don't exhibit much of a symptoms. By the time you exhibit symptoms, it would be way too long. You might have to go for a scan, and doctors say this is quite an aggressive tumor. It is a grade 2 or grade 3 tumor or something like that. Then you might have to go for all the surgical procedures and stuffs like that. So early diagnosis is very important, and treatment monitoring is also very important. You cannot really, look at a structural image and say that this is behaving like this. You can say that in a way. You can say that this is a region of concern, yes, but not much about how this is responding to a tumor. Sorry, a treatment, and how this is helping us in prognosis. It's a bit tricky in that way with just structural information. And that's where all this sophisticated scans coming in, and multi-parametric MRI, as I shown in the previous slide, is taking up the picture. Now let's look at the clinician's perspective. Suppose somebody with a brain tumor comes into the clinics. There are different clinicians coming into the picture simultaneously. You might go to a physician first, maybe with a symptom of headache or something. Consult a physician. Physician will say, okay, I think there might be something wrong structurally inside your brain. We might have to go for a scan. And depending on the symptoms, how severe it is, if it is a stroke-based symptoms, probably they might ask you to go for a CT. Or if you have the facilities, maybe you might go for a diffusion-based scan in an MRI. It's just coming in recent days. It's a wonderful tool to kind of look at it in stock. But yeah, basically you will go to a scanning center, get a scan, and then you go to a neuroradiologist. Here, his job is, have a look at the image, have some matrices, how deep the tumor is, what are the components of the tumor, if, what percent of the region is comprises of water or edema, what portion comprises of some of this active tumor regions, what area is growing, what area is not growing, what area is already dead, what area has all this blood perfusions. And they do it subjectively, right? State of art is subjective, where we could come into the picture. You could have an automated segmentation. You could have differentiation of different tissues. You could differentiate between edema part with the necrosis part. You could differentiate with active tumor region with a new budding tumor region. You could do all those sophisticated classifications, and that would help them in identifying where to take the biopsy. The important thing of biopsy is, it gives you the grade of the region that you takes. And generally, when you go for biopsy, you consider the highest grade. Suppose you take a bunch of cells from a region, it might have grade 3 cells, grade 4 cells, maybe grade 2 cells, depending on how it grows. Generally, in biopsy, they consider it as the maximum grade. They consider it as that classification. Uh, Here, if you have some of the quantitative information, you could really stratify it. This part of the brain tells you that this part has a high grade tumor, this part is kind of still growing, and all those sophisticated information. And neuroradiologists then might talk to a neuro-oncologist and a neurosurgeon. They kind of plan how to do the surgery, and you might have the same kind of pipeline for post-op analysis. After the surgery, you need to know how the patient is responding to the treatment. You want to know what is the status currently, what was the status before, pre or post op. You might want to compare. Some radiations might cause, there is a case called pseudo progression. In some people, tumor progresses after radiation therapy, and it's called, normally we call it tumor progression. But once there is a case called, which is called pseudo progression, which is not really progression. It might looks like progression in MRI images. Even if you measure physiology, it might look at progression, but it is not really progression. It's an effect of treatment. You could really do some classifications, machine learning techniques, AI, or whatever applications that is. You can play with those numbers, features, to say the certain. See, I looked at this image. I had a model that tells me that this is not really progression. This is kind of a pseudo progression which might fade away in a given point of time. That's another aspect of the story. So neurosurgeon and neuro-oncologist will also have that treatment plan according to what you give from your numbers. And as I mentioned before, all these technologies and atlases that we prepare is based on a mean global atlas, right? But different people has different responses. Everyone's physiology is different. Everyone has every different kind of responses, different kind of lifestyle factors. So, any question? I could see the hands up for Nina. Maybe you can note down your question. I can handle it later. So that's the role. And as an imaging scientist, I kind of play in this area where we kind of develop techniques that could measure more personalized informations from individual scans. And there is another area of this pathologist that works with biopsy cells. They also have a subjective look at it. You could enormous opportunities there, cell line images, very hard to segment out. You could even look at nucleuses and different histological classifications, a bigger domain out there. So predominantly, I kind of focus here, and I'll be talking more about this. One such example is this, as I mentioned before. If you have a tumor region, you could, the green is a necrotic region. Here, the blue is an actively growing region. Uh, uh, what you call it, maroon or whatever it is. This is a non-enhancing tumor region, and the whole edematic portion here. So that's one example. Apart from this, we could really measure physiology. I'll show you how. This is one such technique which is called dynamic contrast enhanced MRI. What we do is we kind of inject a paramagnetic contrast agent, which what it is does, which since it is paramagnetic, it reduces the T1 relaxation time as I shown before. And if you acquire the images, let's explain it using this graph. You have some baseline images, say 1. At 2, you inject the paramagnetic contrast as shown here. You do it intravenously. This goes to the heart lung system, oxygenates and pumps into the brain or whatever tissue that you are looking at. We are looking at brain, so let's focus on brain. And now it reaches a peak, goes to all the vascular tissues that I mentioned before, reaches the peak, then eventually washes out. That is the first cycle. Uh, Part of them are not washes out, again have a recirculation, and there are multiple recirculations. And if you continuously acquire these images over time, you would see something like this. And you could see an enhancement at the tumor region here. That's the beauty of this, You go for it, you inject it at this time, it eventually goes up, reaches the tissue, it starts washing out. And if there is a tumor region, what happens is brain has an important property called blood-brain barrier, which blocks external particles to reach into the extracellular or extravascular space from the vasculature. It need only what it need. So blood-brain barrier is built for that. But if there is a tumor region, generally the blood-brain barrier is broken down. So the contrast agent that we inject leaks into this space. And that's why you see only enhancement in this tumor region. If you draw something like here, you won't see that enhancement. as I shown, you will see something like this, go up, wash out. But in a tumor region, since this contrast region leaks, as I shown here, this will change the signal intensities of those profiles outside the vascular space, and that will create an enhancement pattern like this, as I shown here. So we have the red blood cells and plasma. This contrast agent mixed with the plasma reaches at the tissue of interest at a time called bolus arrival time, and it mixes. If there is no blood-brain barrier breakdown, it leaks out into the interstitial space, and then we have this beautiful curve where we can play around with multiple mathematical models, right? Another way to look at it is like this. If we have an intact blood-brain barrier, it comes from the artery, goes out through the vein. But if it is not, it leaks out. And based on how it leaks out, you could have this different kinds of, graphs. Say, if it is a high blood flow, you would see a steep like this. If the tissue has higher blood volume, you will see a higher peak like this. If it is just an arterial voxel, you will see a voxel like this. If there is a vascular recirculation, you would see something like this. So different, depending on how the underlying physiology is, you would see multiple curve patterns, and you could then really play around with it. And traditionally, when it all started with this DCMRI module, typically they classified into three different tissue groups, and based on how those tissue groups are, they basically made a classification. They manually drew an ROI and looked at it and say, this is a type 2 tissue. It doesn't look that enhancing to me, but there is some minor problems, and like that. Now, there then came this semi-quantitative analysis where people kind of looked at different properties from the graph. They computed some of this, what area under the curve or slope, or how the slope goes up, how the slope goes down, or all of those things. And then they said, this, as I said before, this has a higher intake slope, so maybe blood flow is higher. This has a very higher peak, so maybe blood flow is higher. So that's how they made it. And later on, people came up with all the sophisticated modeling. You don't have to worry about all this modeling. What I'll give you a brief overview that every voxel, we treat that signal from every voxel comprises of multiple models, multiple uh, uh, compartments. Basically, here IPS stand for the plasma space, which is basically blood vessels. Plasma is what it takes, and we have the extracellular, extravascular space. Here, what it does is, it leaks, the contrast agent leaks from here to the extracellular space. If it is intact, it doesn't leak. So based on different boundary conditions and assumptions, we could really make up, what is there inside. So that is one part of the ground truth creation that we could do. We could do this sophisticated modeling to work with it. That is, that's really helpful. Later on, once we have the standard models, you could always train any model, right? You could train any model to have a brief idea. You can tell the physiology behind it. Now, if you look at, so this is two cases. One is a low grade case, and one is a higher grade case. I've segmented and marked regions here. uh, Two different types of imaging. One is, as I said, a flare, which shows you the fluid part enhanced. Here also flare. These are just a T1 weighted image. If it is a higher grade, T1 weight shows enhancement curve like this, since there is a higher barrier breakdown. But if it is a low grade, this here in this case, it is mostly edema. You don't have any signal tissues. So you see a highly noisy curve like this. And if you look at the amplitude, see, this is around 10 times, which says, at 10 times of contrast is kind of leaked into it. That is all those numbers are features for us, right? We take care of these numbers, and we kind of predict few things with it. And you don't really have to worry about these parameters. These are some of this blood flow and blood volume information that I extracted. You don't have to worry about what it is and how it is computed, but I just wanted to show an example of how we do it. And that's how it uh, kind of computes, and we see a real nice structural scan here. Also the structural information here to kind of work with it. Now, this is the application side of that. You could really take some of these parameters and do a grading, quantitative grading, and this is some machine learning models that we trained with all of these parameters, different parameters that we compute from these curves. Different models gives us different parameters, and we computed that, and we try to have a model that could predict the grade. And you would see blood flow, blood volume, a pretty good accuracy with around 0.89, 0.9. And this is one clinical application where we kind of use these models in a routine clinic at Fortis. And here you can see for a brain tumor patients, they based on a cutoff value, we have this, uh, we could say if it is a low grade or a high grade tumor. Now, when we develop and deploy these models into clinics, we have to treat few things. One is, let's talk about the development aspect first. You have to collect the data. You really need a lot of data. The one of the good things with MRI is you get multi-slice data. What if you acquire the whole brain, it could be, if it is say a 5 mm slice, thick slice, you will get around 20 slices for an average human being. It is somewhere around 200 mm or something. So each slice is a different information, and you collect all this data, do some pre-processing. Different data will have different alignments. You register everything together, uh, extract features, structural information, so on, whatever, you can have the physiological information I shown before. All these techniques, you do the sophisticated feature selection, feature extraction, dimensionality reduction, or whatever it is, and you do the model training. Now you have a model, and you have to deploy it in the clinic. But while implementing, the problem is that you are giving the model a really new data, right? It might have something very different than the data that you have. Okay, you haven't covered every population, right? So you would get that. So the next thing is you have to really harmonize, uh, different datas. You really have to tweak it from an implementation perspective before deploying it. And ideally, you would have much more multi-dimensional, lifestyle factors or different factors to put it into the picture, so that you say that, this is information from the images, but we also have some of the other information regarding their lifestyles or other factors. So that all together bunch up, and you could really pick up this natural history with all this image information and kind of club it together to give a better overview of how generalized, universal purpose thing would work. Now, one more application here is, we talked about carving out tumor regions from the brain, but one important aspect is, it affects our daily life. It might be associated, the region that we curve out might be associated with, a language area or a daily functional area, which is really an anomaly, because as I mentioned before, each region interacts with some other regions, right? We have a total complex graphical network. So if we carve out one of the nodes, it affects the communication to all other nodes. So that is really problematic. So there is another important and vast domain of literature that talks about, how it affects the brain regions. And that's another region that you could work out if you have a functional MRI or some multi-dimensional MRI information. You could look at, this way. Yes, this way I could kind of take out the tumor regions. But what does the other techniques tell us? What does a functional MRI tell us? Or what does a diffusion tell us? Can I see some anomalies in that as well? Yes, you could. Maybe you could, in this case, this patient had a tumor here. If you take out here, that affects some of the other parts as shown here. So that's another. And here they have really shown, this is a group average map. They have shown that, these regions are having anomalies in their brain functions just because they had a tumor, this region. That's another clinical way to look at it. These all things, structural MRI wouldn't give. So there is a bigger plethora of regions that you could play around with in the domain of a brain tumor. It really depends, what model you want to use, what data that you have. All things depends on multiple factors. But at the end of the day, the question should be, I'm doing some segmentations or stuff like that, but does this really affect a clinical routine? You might do some segmentation, but clinicians already know that the tumor is there. Then why do you want to do a segmentation? I mean, they don't really clear. I mean, neurosurgeon might not begin because he says, once I open the skull, I know where it is. So I don't want to look at the images. So that's where you bring a lot of information from outside instead of doing for the sake of doing, but you give some information for the clinicians to do it. I want to share this data set with you. This is a very, very famous brain tumor data set, which is published from University of Pennsylvania. They have they kind of call for challenges for segmentation. They have very large amount of data. You could start playing around with this data if you are kind of interested in that. That's about brain tumor. All those examples of brain tumor that I've shown you, you could really see some structural changes, right? You could really see that there is something going on in the scan. But there are some set of diseases which we call as small vessel diseases, where you look at the image, you won't see anything much, explicitly on the images. But that people might have little bit effect on their daily life. They might lose their cognition. They might forget things. There's a well-known quote about Albert Einstein. He used to do the research, walk home, put the stick, on the chair, and he kind of stand into the wall instead of doing the other way. So these are some cognitive changes that affects the brain, which might not be clear when you do a simple structural scan, which is a plethora of small vessel diseases covers from Alzheimer's to dementia. Dementia is more of an umbrella term where you have a lot of types of components come inside that. It could be due to vascular regions. It could be due to genetic reasons, Lewy body dementia, or maybe for Alzheimer's, it is accumulation of tau protons, tau proteins, or amyloid beta accumulation. So different. These days, people are coming up with new theories of lymphatics, where they say that the waste clearance is affected. That's why people have dementia. But most of this dementia-related problems are uh, kind of diagnosed in a later stage once all those symptoms in the structural scan are separate, but it proceeds with a lot of other factors. And that's another area of my research, that we try to figure out how, for an aging brain, how we can kind of predict it from an earlier time. This is some statistics of dementia patients. I mean, normally they say a lot of people have dementia, which is kind of get undiagnosed. And the projection for 2015 in the world is, around 132 million people is going to have dementia. The main problem is early diagnosis is a bit harder. This is group average images of people from 20 years to 90 years of normal aging. You could see, from the one important aspect to look at is this ventricle space. If you go from 20 to 90, this ventricle space kind of big enough, and this takes the space of gray matter, which eventually restricts the amount of blood that our brain gets. And there are certain uh, features that we could see from images, like the gray matter volume shrinks, whole brain volume shrinks, the thickness of the cortical side of the gray matter reduces. If you can appreciate really from this image, you could really see this thick gray matter here. But once when you come into this old age people, the gray matter kind of thins up. So there are different structural features like that you can explore around for a healthy aging brain. But if you talk about some pathological conditions, generally for cognition related things, you would really see some of the symptoms like white matter hyperintensities, small bleeds, which has as I mentioned for tumor, which might have this blood-brain barrier breakdown, and some of this lacune spaces around the ventricles. So these are some of the features. But as I mentioned here, these features come up in a later stage. So by that time, we might have already exhibited some of these symptoms. This is one of the paper that recently came out. Very, really interesting paper. They used some open source data, which is Human Connectome Project, UCLA Connectome Project, OASIS. These are different open source data, Scobre, and they have taken some sophisticated scan called diffusion, which gives us how white matter tracks. In effect, neurons are aligned, and more aged we get, some of this, you could derive some of these properties called functional anisotropy, which means how anisotropic or how non-isotropic it is, the fibers are. What is the diffusivity? If it is more, there is a high rate of diffusion, more heterogeneous diffusion, it is abnormal. So there are different parameters that you can extract from this diffusion scan. Then you have all those structural information that I mentioned before, the cortical thickness or, gray matter volume, white matter volume, all of those things. You could register, as I mentioned, different things would be in different space. So registration itself is another machine learning problem, which is mostly solved these days, particularly for brain, but not for other regions with a lot of motions. Then, they have basically cross-sectional and longitudinal data. They trained it with both structural and diffusion separately, combined it, and then they had the whole structure. And what they did is interestingly, they did some age prediction. So basically, you have here on the x-axis, it's very hard to look at it, I know, but eventually I will explain this. You have a chronological age, which is your age as a number. Suppose you are born in 1990, you are now 25, that is your chronological age. But your brain age might be different based on the symptoms that you have, based on the lifestyle factors. If you are obese, if you have some other diabetes, hypertension, smoking, alcohol use, some other genetical features. So based on all that, you might have some other chronological age. So if it predict brain age. If it lines in the same line, it says that you are at par. If you're 70, you are 70. If you're 80, you are 80. If it comes down, it says that you are a bit healthy. But if it go up, it says you have to really take care of yourself. Your brain, you are 70, but your brain acts 90. So yeah, all those things. But they have really very good number of data, and they showed this real prediction, which is really important, right? Again, this is a mean thing, and you have all this covariates as age, sex, or lifestyle factors. That's there, but still you could predict, right? That gives you a number. Suppose somebody comes with both of this diffusion and structural scans and tell you, these are my scans. You could compute these parameters, saying, these metrics comes like this. I think my model says that your age is this. You might have this much of predicted age. So that's another application which helps us eventually in predicting all those structural changes that I shown before, like this. You could see over the years of 0 to 30 years how your atrophy rate moves in different subjects. So those are cognitively normal two subjects, they behave like this. But for people with cognitive impairment, we kind of see a sharp decline. So that's another perspective of looking at it. Now, I was talking about functional MRI a bit. I would give a brief introduction about functional MRI. This is basically an oxygenation dependent signal. Whenever you have any thought, suppose you are attending this talk, you're looking at the screen. When you see this picture, some region in your occipital region brights up, which means the occipital region in the brain requires more blood to process those information that you see. What that does is eventually, since the metabolism increases there, the brain needs a lot of blood there. So it pumps up a lot of blood, which eventually increases the signal because a lot of oxygen goes up, and basically a lot of metabolism, and you get a better contrast at these regions, which is what's shown here. A simple experiment, as I said, somebody is in the scanner looking at an image. We are simultaneously measuring their signal change, and we could do some of the sophisticated analysis. To just explain it once more, you might have some task, maybe hand movement, maybe looking at an image, listening to something. So based on that, different areas will light up, right? If you have a hand tapping, some areas in the brain will evoke. If you have a visual task, then your occipital region will, or visual cortex will light up. So based on that, you have all this blood oxygenation going up, blood flow going up, and you see the signal from this brain venule just because you have a deoxygenated blood that is going into the veins. And you have to remember that deoxygenated blood is paramagnetic in nature, which reduces the signal intensity. And that reduction in signal intensity we see as an increase in signal in the MRI, and you always look at those features. And now, you know how it works. Your brain already have a response function. Your brain already knows that, something like this comes up. If I see a screen, it should behave like this. That is a response function of the brain. And you give some stimulus like visuals, as I said, and it works with, this is a basic convolution operation. And you see a complicated signal like this, which is what we expect. So in some cases, as I mentioned, we have a norm of what we should expect because we know that how the hemodynamic response function is, or we assume how it is, and then we kind of track it. Right. Then we could really look at in a statistical domain how it is playing around, as I shown here. Some task. Suppose I'm doing a visual task. I have this brain signals from here. Each of this signal in the row. Let's assume each of this metric has different slices. Each slice has a different square plots, which is a voxel. And if you look at it, you see the signals here. And now if you look at the signal, you would see something like this. Whenever you see some images, you would see the signal intensity going up. And now, you have signals from different regions, different voxels. Then this is your game. You know how to play with, sophisticated models. You know how to play with, how to handle this data. So you do all this metric-based analysis calculations, and then you say that this part of the brain is working with that, and all those things that we talked before, and we could make that anomaly. Somebody's mic is off. Somebody's mic is on. Could you please shut it off? Okay, it's Jayalakshmi. No, she's not listening. Okay. Now, this is the same thing. A recent paper published. They have the functional connectivity that is computed. Okay, we have the atlas that we have here. We created a norm, and then they scan some of this, functional maps or functional MRI images from different populations with a set of conditions, and they trained their model. And similar to what we have seen from the diffusion and structural, they have predicted the brain age. So basically, then you have, the brain age. As we discussed earlier, we have the predicted age and the true age, and that's the whole process of this. Again, some sophisticated statistical modeling, but you could do this. One other interesting aspect to look at it is there's a paper that came out in Science few years before. What they did is they did something similar to that I explained before. They showed them some images, extracted the functional images. They looked at the functional signals, how they behave, and they decoded that. And they tried to replicate what they looked at it from the signals, and they were pretty successful. If you look at it, from a highly complex signal like a functional MRI, it is very highly complex because functional MRI signal depends on blood flow, blood volume, oxygenation, metabolic rate. It's a very complex signal. It has very higher amount of confounding factors. It depends on how hematocrit level is and different things. And then they have recreated this, which is really impressive. And I'm looking forward to some of their papers from in the future, because I know that they are going to train this model further and further, especially with the current evolution of whatever deep learning that we have. This is one of the out of the box thinking, not on a clinical perspective, but maybe in use in clinics in the future. So where we are, in the perspective of dementia. This is a brochure or a poster that was released by NIH few years back. They say that we do all this sophisticated modeling, but on a group level, you do some of this analysis on the data set that you have might not be reproducible across different data set across. Maybe you have a prediction from 1.5 Tesla images, but not work on a 3 Tesla images. Maybe you have some data set from center A, don't work at center B, all these things. Second, you have the group analysis, which might not be accurate at an individual level. And how you might find some of these correlation factors. Say, right, you acquire images, you compute some of this blood flow. Say you compute blood flow from people who has a habit of smoking for 20 years, and you plot a correlation, and you see a high good correlation, right? But correlation is not merely a causation. So you have to really differentiate between correlation and causation. So these are some of the areas that we have to explore with the kind modeling that we have. We have a lot of data, we have a lot of models to play around with. Most of the things are coming out open source, but the real thing is you have to ask the real good questions. Am I able to find a diagnosis from that a general clinicians cannot objectively do? They have some of the tools with them, but they cannot do. Yeah, you can say that, I have a model that predicts this, or I can do this, that's one part of that from a diagnostic side. Second is, as I said, correlation versus causation distinction. And you also have, to make it more personalized, harmonized, and generalizable, and more explainable. It's not about, feed data and kind of coming up with some sophisticated things, some metrics. I have this much of accuracy, this much of sensitivity. No, it should make sense in the real clinical domain. That's when they use it. Just before closing out, I just wanted to show a couple of data sets on neurodegenerative diseases. These are some of these diseases and projects. Human Connectome is one of the biggest projects. That's from Harvard Medical School and Massachusetts General Hospital. They have.
Please mute.
Okay. So that's one. So you could really access the Human Connectome data. You could go to. They have neurodevelopmental studies for.
Hello? Hello?
Excuse me, could you please mute? Okay. Okay. So yeah, you have different domains of studies in that.
Sorry.
Human. No. Yes. So you have young adults who are growing up. It's called HCP, Human Connectome Project Study, and they have certain lists of softwares. Like you can use their own softwares to process the data. They give you the data. So you do the processing, set the ground truth, and do whatever sophisticated analysis you want to. You can build your own models. The data is out there. Few people have already published. You can look at Google Scholar, Semantic Scholar, or whatever it is, PubMed. You would see a lot of bunch of papers with that. So you can really play around with this data and come up with your own ideas, analysis. And you can talk to clinicians if it is hard. They'll give you interesting ideas. Clinicians, they have a lot of problems, and they need people to solve problems. So you could look at some of this data. There is an open source website called Kaggle. It is Kaggle, which also has a bunch of open source data from some of the other body regions like brain, knee, prostate, and other. So that's also explorable. Finally, this is a workflow of all this, not just AI, all the statistical modeling could fix in. Maybe Vidur might have talked about acquisition yesterday. From image reconstruction, you could build sophisticated tools for visualization and computation. You could help clinicians with all this analysis that they cannot do qualitatively. You could quantify metrics. Once you have numbers, it's very easy to compare across. Different people might have different head size, their some of the lesions that you see might be comparable with respect to their head size. So numbers are all it is. So you could really play around with these numbers and have an idea of how it works. And these days, people are coming with automatic radiology reports, all those fancy things, which is another growing up areas with the evolution of this large language models. Once you all have all this first stage of data from acquisition to their lifestyle things, you could generally um, have an automated, uh, report, as I shown before, that could say, this region looks like have a value like this, so this potentially looks like a tumor of this grade, and maybe you could correlate it with clinician, or you could also add some of this neuropathological information from this with this neuroradiological information and have a combined multimodal approach. So a plethora of opportunities to play around with. If you look at it from an imaging side, if you look at it from from another pathological side, you have a bunch of things to do with all these things. And the important thing is it does not stop with diagnosis. You have the prognosis part, right? You want to know how the patient survives. You want to know how it influences people. You give some numbers to clinicians. It's not that clinicians are interested in how the subject survives. So that's another part of that. So you have to really, really, really care about that. And there are different things to work around. As I shown few data sets, you could really Google around and find brilliant data sets around. That's about my talk. So this is my previous research group. This is my current research group and all my funding and collaborative sites. And, as I said, you have a lot of data. So discovery is not that what everyone has seen. It's something like, you think differently and look at what nobody has seen. Thank you.
Thank you,
Now,
Daniel.
let me know if you have any questions.
Yeah, one from chat box, I noticed that one question, it's asked by Vivek Kumar Sharma. Sir, what are the
Mhm.
other data sets? So can you explain a little bit more about what are the data set you are using and publicly available data set and
Oh, yeah, that's a good question. So, yeah, data is the real oil here. Uh,
who are doing brain area?
yeah. So data is the real oil here. Some of the open source data sets I have mentioned, you can really Google around. You could see a lot of. So there are some data set called ABCD, which is called Adult Brain Cognitive Development Study. There is HBCD, which is also a human brain development study. So there are different open source data sets that we have. There is a UK Biobank data set. Uh, these are open source data. I normally don't use open source data set. My work is predominantly on the local data that we have. We have a scanner here, and I mostly do some of the developmental studies. So we acquire the data that we want. We also have few collaborators that kind of share their data. It's really, either you can use open source data that I have shown here, or you could really talk to some of the clinicians in your area if you have a hospital there, and they could, they acquire a lot of data. They could give you some of those data, and if you can convince them that you could play around with the model, and I think they'll be helpful because there are a lot of, especially these days in the past 5 or 6 years, clinicians especially are really interested in this quantitative analysis.
Yeah, yes, he is asking like in addition to the Bratz and Kaggle, any other kind of
So
open
that's
source?
what I mentioned. You have Human Connectome project. Uh, so you have here, yeah, Human Connectome project. This is one. You could look the link here. There is this Alzheimer's disease initiative here. You have the open access OASIS data here. There are a few couple of other data sets which I cannot really. There is ABCD, which is Adult Brain Cognitive Development. There is HBCD. Uh, yeah, that's something that I could recollect
Yeah,
now.
I just add one more point. It's like these public data is enough for developing or displaying the segmentations or any other quantitative analysis like us. And we are okay with or tested with all these data set, then we can approach the local things and yeah, convince them and try to test those data. First, we play with the globally available public data sets, and yeah, as Dinil suggested, like we can approach the locals, hospitals, or clinicians and convince them and what kind of approach we have, and they will help us for collecting the data sets.
Yeah, that's a good point. I mean, before getting there, we should have a feel of how the data looks like. Clinicians will always talk in their own terminology, so we have to be really there. That we have to be really in terms of uh, familiarizing the data set is very important. That's the way to put it, I think.
Yeah. Anyway, thank you, Dr. Dinil, for your wonderful speech related to this brain MRI and how AI is coming into the picture with this MRI of brain images. And you initial stage you explained the basics of these brain working with brain functionalities, and after that you showed some interesting topics like fMRI, and some brain research group is trying to extract the signals related to what they are watching, something like that. What I understood is like that, and so much hope and so much opportunities in this particular MRI or brain research field, which is I think it's a globally it's one of the hot research topics. As per our FDP, it's also AI and like imaging. So your work is and your contribution is very helpful for the community, I guess. And thank you once again for your time and cooperation with us. Thank you so much, Dinil.
Thank you for inviting me. So we are all good, right? Good to leave, or are we still open for discussions?
Yeah, for 8 minutes remaining. So anyone have any questions, please unmute and ask questions.
Sir, can you identify the tumor at the earliest stage of that is in the initial stage?
Yes and no. I mean, yes, in the sense it really depends on when the patient comes for the screening. But yeah, more or less, we have the current research stands at a point that you could really tell that, if it is which grade once you show up at the clinic. I mean, at the early stage, the main challenge is, it's hard to show up with the symptoms.
What about the accuracy, sir?
That's a very good question. So that really depends on, that's the main challenge that our current domain have, you might have a very good accuracy in suppose some of the data set that we have, I've shown 90%, 95% accuracy in some of the data set that we have. But maybe the same model might not work in the data with other centers. So we have to come up with some of the, generalizations or harmonizations. And that's what we are working towards. Our aim is to make it 100% accurate, but we always have some false positives or,
What about the implementation process, whether it is implemented in any private or government hospital? Is it possible if you are getting got the permission like that?
implementation of the models, you mean?
Sir,
Yes. So that really depends on multiple factors. One, you have to have some what we call IRB, which is Institutional Review Board. You have to have a clearance from them, which is similar to some kind of clearance. And most of these things are still at the preclinical stage. You have to do some, all those statistical procedures of clinical trials and stuff like that. But to start with, if you have a good model which works with, and you have a good clinical collaboration, they would use in the clinic to aid the diagnosis. It's not replaceable or all those things as a standalone. But they would, as I saw in one of our examples, the radiology report that I shown from Fortis is our own analysis. I mean, the pipeline that I built, they are using it there, and they are using it, have an idea of what the tumor look like, and they could really say with the cutoff that we set that if this is a high grade or low grade. So yeah, it really depends on what protocols, what imaging. MRI is very sensitive to imaging protocols too. So a lot of things to harmonize with. So that's one of the challenges that we have currently, and we need people like you to work on that.
Thank you, sir. It is very informative session. If you possible, kindly share your PPT. Thank you so much.
Sure.
Thank you, sir, for your wonderful section.
Thank you. So it's all set to close now?
Yes. Okay. Without any other more communication or any other questions, we can conclude now the first session. And thank you once again. Thank you, Dinil. Thank you so much. Have a nice day.
Bye-bye.
Hello, sir. Good evening.
Yes. Hi, sir. How are you?
Yeah, fine, sir. How are you, sir?
Yeah, I'm good.
Yeah.
We will start within 5 minutes. Okay, sir.
Yes,
Just
sir. Yes, sir. We will.
try to share the screens and check all these things are okay. Then we can start around 7:30.
Yes,
Sir,
sir.
actually, the feedback is not working.
Okay. We will do. Wait one
Okay,
second.
sir.
Okay.
Sir, my screen is visible, sir.
Yes.
Hello.
Yes.
Yes.
Good.
Yes. Okay.
Hello. Hello.
Hello.
Sir, link still is not accessible. Feedback.
Okay. Rafiq, sir, will resolve the issue, ma'am.
Okay.
Please wait.
All participants, sorry for delay, sorry for confusion. Now we will prepare and we will share soon. Please wait. Yeah, please use this one.
Good evening. We are now beginning the second section of second day of our 6-day faculty development program on advanced artificial intelligence and machine learning techniques for medical image application. It gives me great pleasure to introduce our esteemed resource person for this section, Dr. S. Gopalakrishnan. Dr. Gopalakrishnan is a senior professor of biomedical engineering at PSG College of Technology, Coimbatore. Has been serving since 2008. He earned his doctorate degree in information and communication engineer from Anna University and also hold an IBM professional certification in data science. His research focused on using artificial intelligence to improve medical practice. He has published widely on topics like lung disease diagnostics, rehabilitation monitoring, disease classification, COVID-19 detection, and brain tumor. We are truly honored to have such a distinguished professor with us today. His insight will surely inspire us and provide deeper understanding on how AI transforms healthcare application. With great pleasure, let us welcome Dr. S. Gopalakrishnan to lead wonderful section of day 2.
Okay. Thank you very much for the nice introduction. First of all, I would like to thank Dr. Rafiq for giving me the opportunity to share some of my views in the application of AI in healthcare sector. And I also thank all the participants for showing interest and joining this evening to share your knowledge with us. And moreover, I see this is a platform where we can share our knowledge so that we can perform well in the future work. Okay, let's start with the session. So today I'm going to discuss something regarding this application of artificial intelligence in screening and early diagnosis. First of all, if you look at the definition of this screening or early diagnosis, so early diagnosis is the identification of a disease or condition at an initial stage. Say, for example, if a particular disease shows a symptom, and if you rush to the hospital, by the time the disease may be approaching the advanced stage, say if it is a cancer-like disease or some chronic kidney disorders. So if you have a tool to diagnose these diseases in an early stage, we can give a better solution for these diseases so that we can easily treat the person. And there are many methods for this early diagnosis. The one of the method is the screening. So we know what is early diagnosis. Early diagnosis means identifying the disease before it shows symptom. So once it shows symptom and it is in stage 1 or in some mid stage, okay, so there is a rule called prevention is better than cure. So we got to identify the highly risk people for enrolling this screening test. That is the very first thing in early diagnosis. So it is very important to this screening, and we should also properly choose the population for screening. Say, for example, if you are performing screening of lung cancer, we should carefully choose the population. Say, for example, the person may have a history of lung cancer in the family, or the person may be working in a coal or mine, or the person may be a traffic constable. So these are the places where that is the cancer causing agent, that is the carcinogen is very high. So we can easily identify these high risk people for enrolling this screening test. So by means of regularly performing this screening test, it is possible to identify the disease in an early stage so that we can provide a better diagnostic, that is a treatment, and also it improves the lifestyle as well as the survival rate of the person. Okay, and in order to confirm the person with suspected disease, we should also go for some other test after identifying the high risk people during screening. And it is also important to monitor high risk people. Say, for example, as I mentioned, the family history or based on the risk factors. Okay, so it's not only for lung cancer screening. So let us consider a woman aged about 35 or 40. It is recommended to go for regular screening of breast cancer. This is me. I hope
think
my
so.
voice is audible, right?
Yeah.
Okay.
Yes, yes, some participants. Okay.
Okay, fine. So it is important to monitor the high risk people, and only by means of screening, only we can diagnose the disease in an early stage. Okay. So these are all the benefits or advantages of performing this early diagnosis. So the first advantage is better prognosis. So if you identify the disease in an early stage, so we have a lot of choices for the treatment, right? So early treatment improves the patient outcome. That is, it increases the 5-year survival rate, as well as it avoids lot of complication. Okay, once the disease approaches the advanced stage, right? So we cannot treat the person, and also the cost of the treatment is very high, right? So if you find the lung cancer or breast cancer or some other disease in an advanced stage, the choice of treatment is also very limited, and also the person may lose his quality of life. So he has to spend a lot of time in the hospital, and also the person is we are putting that person in a very high risky state. So these are all the benefits of early diagnosis of diseases. And let's see some of the limitations of conventional or traditional diagnostic methods. Say, let's consider this particular thing. Let me show you an example of low dose computed tomographic image. So this is a tiny tool called Image or Refugee. So it is a Java-based tool. It is used for viewing the DICOM image. Okay, let me open that particular image. So this is a particular slice in this thoracic CT image. Okay, see, if we look at this particular image, see, there are a lot of bright like that is round like bright structures, and also some lines, curves, and many things, right? So this is the right lung, and this is the left lung. Okay, in this thoracic CT, and there are bright spots. Like, look at these spots, right? So these are all called. It may be a blood vessel or airways. Okay, but if you this is actually an actual section of a thoracic CT image. Let us consider, we know the shape of the blood vessel or the airways, which is tubular in structure, but which are aligned, that is aligned in this direction, vertical direction, right? So if you cross section this tubular-like structures, so in the 2D, it's look like a round, okay? But let us consider there are some tumors which may be small spherical in shape, And if you cross-section this spherical shape, and if you look at it in the 2D image, it's also look like a round-like structure. And if you look at the intensity of this particular lung nodule as well as these blood vessels, it's also share the same range of intensity. Okay, so by looking at the single slice, it is very difficult to find or classify whether these bright-like round structures are airways, blood vessels, or tumors. Okay, so let me show you how the radiologists are reading this screening lung cancer images. So actually, this is a volumetric data, right? I'm loading image sequence. That is one particular person's thoracic CT image. So actually, this is in DICOM format. It's available in this particular folder. See, if you look at this thing, there is a lot of difference in viewing this particular volumetric data slice by slice. Also, looking at the single slice, right? So let us consider the thoracic region of the person is slide in this vertical direction. That is axial cross-section view of this thoracic CT image. So let's start from the top, and this is slice 1, 2, and so on, right? See, look at, I'm playing this series of images one by one using this particular tool. See, if you look at this image, right? So there are some bright-like structures. So this is how radiologists are reading the image. See, look at these bright-like structure, particular look bright round. So this is moving its orientation from one slice to another slice, isn't it? But if you look at, there are some bright-like spots, say this one, right? So this is in the remains in the same position in this slice as well as the next one. Okay, see, look at this one, right? See, look at this one, okay? And this particular bright-like structures remains only for two slices. So if it is a tubular-like structure, it spans many places. But there is a small like nodule, so which is about 1 or 2 mm or maximum 3 mm in diameter, which is spherical in shape. So this particular thing remains for only 1 or 2 slices. So while reading this kind of volumetric data, the radiologist may miss this particular nodule. So this is a lung nodule. If you find or diagnose this lung nodule in an early stage, so we have a lot of choices for the treatment. So this is a kind of, this is how the radiologist read this image, and look at this, the entire thing. See, there are many such bright-like structures. So all of these round structures are not lung nodules. So this is not a lung nodule. This is not a lung nodule. See, look at this. But there are some bright. Yeah, this one is a lung nodule. See, look at this. So this is again spans only 2 to 3 slices and also disappears. Okay, so this is another nodule. So we are including thousands of people for lung cancer screening. Okay, so nowadays mobile screening systems are also available. So we are reaching that particular highly risk area, and we are including thousands of people for screening in order to find this lung cancer in an early stage, right? So see, actually, if you look at the low dose computed tomographic image, so this is actually in the order of few hundreds. So it spans from 100 to 300, 400 slices. Okay, so if you say the radiologist is reading these images, okay, so nearly 300, 400 slices and around thousands of patients. See, there is a possibility of error. right? There is a possibility that is the radiologist may miss a small, tiny bright-like structure, and he may interpret that small bright-like structure as a blood vessel or airways. So there is a possibility of missing that lung nodule in an early stage. Okay, so there are a lot of radiological error. So it is because of the following limitations. So the limitations of the traditional diagnostic methods focusing on radiology are human perceptual limitation. Okay, so we cannot look at all the bright-like structures. There are tens of bright-like structures in this left and right line, isn't it? So we cannot focus on all the structures at a time. So possibly we may miss, or sometimes the complex images increases the error rate and subtle lesions often overlooked. Okay. So the second important limitation is the cognitive and interpretive error, right? So misclassification of detected findings, that is the benign tumor may be interpreted as malignant, or the malignant tumor may be interpreted as a benign one, right? So this is because of these nodules are characterized by the corresponding texture features, right? So this is a low resolution image, and it is very difficult to see the corresponding texture present in this small bright-like structure. Okay, it spans about 2 to 3 mm. Okay, sometimes it may be around centimeter. That is not a issue because it is a very big tumor. One can easily characterize that is the malignant one. But if you look at the benign tumor, it is very, very difficult to characterize the tumor, okay, by means of analyzing some radionic fixture. Okay, and there is a variability in the observer. There is observer variability. There is a inter-observer variability, that is discrepancies. That is, if you show the particular radiological image to a group of radiologists, some of say the radiologist one may agree with that particular, say that block one may be a tumor, okay, and the other persons in the panel may not agree with that study or agree with the word of the radiologist one. Okay, so there is a discrepancy among this radiologist itself. This account for 30 to 37% in specialized imaging, and there is a intra-observer discrepancy also. So while looking at, say, the radiologist may look at that particular spot, he may characterize that as a blood vessel or some other anatomical structure present in that image. Then after the some time, so if you show the same image to the same radiologist, so he may that is label it as a tumor, right? So this is the inter-observable discrepancy. This accounts about 26 to 36% upon a re-review. Okay, so there is also a retrospective error rate. So errors are identified in lateral review. It can be up to 30%. Say in the first review, it may be missed by the person, and the later review. So first pass, second pass, we are reading third time and fourth time. So after careful review, so the person may spot the tumor in the radiological image. So this leads to delayed or missed diagnosis, which impact the patient outcome. Say, for example, if the radiologist misdiagnoses the person, say there is a possible tumor in the lung or tumor in the breast mammography image, and if the person mistreats, and this leads to a lot of complications. So after coming for the second screening or second review after a month or after 6 months, so before that the particular tumor may grow and it may reaches to the next stage. So it reduces the patient outcome, that is the survival rate as well as the options for the treatment. Okay, so these are all the limitations of the conventional diagnostic techniques, which is purely based on only the radiologist opinion. Okay, so this is where these computer-based tools are important, and this acts as second tool. It is like an assistant or companion for the radiologist, right? So this will bring up all the suspectable points or the regions in the image, and it will populate all these things, or it may be labeled, right? So the radiologist may not miss even a small lesion present in the thousands of images, because this highlights only the high risk or the most common nodules present in the image. Okay, so this AI tool reduces the perceptual misses, that is about 15 to 20%. Actually, the radiological error due to this perceptual limitation is it's around 3 to 5%. Okay, and among this AI-based companion or AI-based diagnostic tool reduces this error about 15 to 20%. Say, for example, in case of a computer-based diagnosis in mammography, and this is the improvement in this error or misclassification or misdiagnosis. So AI can highlight subtle anomalies present in lung nodules as well as the microcalcification present in the mammogram or small brain lesions. And the combination of this radiologist and AI-based tool, which significantly reduces the error rate. So the study by AICTE-ATAL and published in this Nature 2020. So they enrolled a number of patients, enrolled the group, and they have uses this tool along with this radiologist. That is one group, and this second group consisting of only the radiologist, right? So the result shows that the combination of radiologist with the AI-based tool significantly improves the error rate, or it reduces the error rate. So these are all the that is the role of AI in improving the accuracy as well as the efficiency of computer-based tool, especially used for early disease diagnosis. So these are all some of the applications of AI in early diagnosis. So one is medical imaging. As I mentioned, it is used for screening lung cancer, screening breast cancer, and screening skin cancers. Okay, and it is also used in analyzing pathological images, that is blood smear images, pathological images. So there is a automated system which actually takes the biopsy and analyzes the sample and gives the result, right? So this is another area where AI can outperform the physician or the lab technician. And another area is genomics. So it is used for predicting the risk based on this genomic, analyzing the genetic markers present in the DNA or encoded in the DNA, and it bring out the details, or it is useful for characterizing or it is useful for predicting the disease. Say, by means of careful analyzing this genomic data, one can easily predict he or she may going to affected by this particular disease after a year or after 5 year or after 10 years. Okay, so this is a very advanced or very early diagnosis of diseases. Okay, and another area is wearable monitoring system. So nowadays, if you look at this world, the world is aging, right? Number of elderly persons in the world is increasing every day, right? So it is important to monitor the healthiness of elderly people. So we got to take care of the elderly people. Say, for example, the elderly, the parents may be living in a village and their son or daughter may be in a city, right? So there may be so we want to monitor our parents or elderly people. Okay, so by means of this smart devices or smart wearable devices, say smart watch or simple kind of accelerometer or a gyroscope kind of sensor, it is called IMS sensor. By means of wearing these smart sensors and analyzing the sensor data, we can easily monitor the person. Say by careful analysis of this inertial measurement unit, it is called IMS sensor. We can easily predict whether the person is sitting or performing some task. It is exactly like wearing a Fitbit, and all this Fitbit is capable of monitoring a person. Even it is used for monitoring the quality of a sleep. So this is another area where AI is performing better. And another application of this AI in healthcare sector is so we can develop some predictive model. So these predictive models can diagnose some of the diseases in a very early stage. Say, for example, the AI-based system can diagnose this heart failure after a year or after 5 years, or it is capable of diagnosing the very early diagnosis of stroke. Say, I have gone through one research paper and clinical paper. So in that they discussed that. So there is a strong relationship between this retinal biomarker or the retinal vasculature as well as our brain, that is a neurological neurovasculature, right? So if there is a symptom or if there is some pathological thing that is on this brain or neurological system, that is reflected in this uh, eye. So by means of careful analysis of the retinal vasculature image, so one can predict the stroke in a very early stage. Okay, so these are all the applications of AI in healthcare sector. So coming to the data sets to work with this AI, so there are a lot of data sets available. I have covered only the most important data set, especially for early diagnosis of diseases. See, one of the largest data set in this area is TCIA, that is the Cancer Imaging Archive. So it is mainly focusing on the radiological images like CT, MRI, PET CT, and X-ray. And this is archival of cancer imaging data, and it is originally that is it has data set of multiple cancer types, say lung cancer, breast cancer, and all these things. So this is the largest data set. So one can easily enroll this TCIA, that is Cancer Imaging Archive. Once you enroll this, you are provided with a username and password. Using that credential, you can download GBs, hundreds or DBs of data, and you can. So moreover, this is a well recognized data, and also this comes with ground truth. That is very important, especially you work with AI technique. Say it is a machine learning or deep learning. So basically, this is a supervised learning, right? So in a supervised learning, that is the labeling of data is important. So in case of medical images, labeling can be done only by an expert radiologist, isn't it? So the radiologist only, or that is the expert in that area, can easily say this particular mammogram is having some architectural distortion or microcalcification, or it may present some mass. Okay, so in order to assess the computer-based technique or AI technique, so in order to evaluate the performance of this AI technique, we need to compare this performance with the standard one, that is the gold standard, that can be done only by the expert in that area. Okay, so another important data set in case of neuroimaging is the Alzheimer's disease data set. It is called ADNI data set. It is meant for Alzheimer's disease progression as well as early detection. And the third one is OASIS, Open Access Series of Imaging Studies. So it is MRI, structural T1, T2, and FLAIR TTI cognitive clinical data. And another data set is HAM 10K. So it is a human assist machine with 10,000 training images. And moreover, apart from these images, so participants, I hope you may heard about the Grand Challenge, right? So every year there are a lot of challenges are posted worldwide. So if you enroll for this challenge, Grand Challenge, okay, so you are provided with the training data. So you can enroll along with your team. So you will receive 10,000 or 100,000 of data for developing your AI model. And once you develop the model, and after some time, then you are also given with the testing data set. So you can test your developed model and you can send this to the poster, right? So, and your model may be compared with all other submission, and based on the score that you get, you are rewarded. So recently I also received, I've seen that one, there is a uh, challenge posted internationally. And so similarly, see, every year there are a lot of challenges posted worldwide. So this is the place where you can easily access the data, and you can apply your technique, that is AI model, to solve that particular problem. Okay, and you may come across this particular thing. What is AI, ML, and DL? To be short, AI is a broad science of creating intelligent machine that mimic human cognitive functions such as learning and problem solving. So under this umbrella of artificial intelligence, there is a subset called machine learning. So ML is a subset of AI which uses algorithm to trace the data. Say for example, this ML technique requires handcrafted engineer, right? Say, for example, in order to assess or in order to read the particular radiological image, or say, for example, it is a machine vision task. So if I show the machine, so machine cannot say I'm showing this particular object. So this is a mouse. Machine may not see as we perceive, right? So we know this is a mouse, or so some other thing, right? This is a pen or something, right? So machine perceives this as a pixel. So it is a intensities. So array of intensities, right? So in machine learning, so we can easily classify objects by means of looking at the features or attributes of this particular object. Say this is black in color, and look at the shape of this. So this is about this centimeter in width, height is this much, breadth is this, and this has a wheel. And so by means of carefully extracting all these features, okay, so we can categorize this as mouse. Or if you take some other object, this is a see, look at this, this is chalk, so it has a particular color, right, as well as shape. Okay, so here we can teach this machine to classify things by means of extracting these attributes called features. So the success of this machine learning technique is based on how well we are extracting these features for classifying things. So it requires a lot of knowledge, a lot of mathematics, and so uh, only by careful design of this feature generation, then only we can classify these things very accurately. Then another subset of this ML is called deep learning. So in case of a deep learning, it doesn't require any feature extraction or feature generation. Say, for example, we are showing this mouse image. Say you are having thousands or 10,000s of mouse images. So see, if I show this is a mouse. If I show some other brand or some other color or some other shape of mouse, so we can easily interpret this is a mouse, right? Likewise, we go to collect all the varieties of mouse, and we can label it as mouse, and we can show the computer this is mouse. Okay, so the computer can able to learn all the variations or all the unique features associated with this mouse. Okay, so for that, no need to extract any attributes, or there is no need to generate features. Okay, so the amount of complexity involved in training a deep learning model is very low as compared to ML, because as I mentioned, the success of this ML technique is purely based on the high level features that we select, so that easily distinguish different objects or different patterns present in the medical data. Okay, so And one more important thing is, so you may be confused when to choose ML, when to choose DL, or sometimes we may combine these ML and DL. So it is called hybrid method. So nowadays these hybrid techniques are performing better than ML or DL. There is a combination of both. Okay. So when to choose ML? So you are given with one smaller amount of data, and the data set is a well structured data. So it may be a image which shows very clear outline of the tumor, or you may be given with the features extracted from this tumor region. So it may be available in the form of a sheet, or it may be an image, or it may be a signal, but it is a well structured data set. But the data set is very, very limited. Say you are having only hundreds of cases. Okay, so in such situation, we may go for ML technique. Okay, so when the feature engineering is feasible, that is, domain experts can define the discriminative features. Okay, say as I mentioned at the beginning of this session, I have shown a single slice of this lung image, right? So it is very difficult to assess whether that particular bright-like structure is a tumor or a blood vessel. Okay, only an expert in that domain can easily teach us this is how we are interpreting, or this is how we are characterizing the tumor, and this is a tumor and this is a non-tumor, right? So we need domain expert knowledge. Okay, how the radiologist is discriminating different structures present in the radiological image. So we have to acquire that knowledge, right? Then only we can come up with a better discriminator that extract or that will capture that particular feature from the radiological image. So this is a very important step while choosing this ML. Okay, so some of the examples of this ML based AI techniques are predicting the diabetics from the patient record, say from age, body mass index, and some test result, right? So this is a well structured data. So here the age of the person is so between this and BMI where is given, and so the test result is given. So this may be kind of a table, right? So if you have this kind of structured data, you can go for this ML. And the another example of this ML technique is early triage using basic clinical and demographic data. So when the person is approaching the triage area in the emergency medicine, it is important to prioritize the person. Okay, during this COVID time or in the emergency situation, there are hundreds of people may rush up to the hospital in the emergency ward, right? So it is important to decide the which patient is to be treated first. So based on the health condition. So there is a system, right? AI-based system which can easily get the basic vital sign of the person. So this assess the basic vital sign, and by careful analysis of this, so we can categorize the person. Say the person is assigned with color, say green. So green means so there is no emergency. He may wait for another half an hour, another 10-15 minutes. So the code is red. So in that case, the SpO2 is far below the rated value. So it is lower than 85%, and the blood pressure is also very, very low, and the temperature may be very low as compared to the rated value. So in that case, he may be classified as red. So he needs immediate treatment. So in this area, so these AI systems are completely based on this structured clinical data, right? Say SpO2, temperature, that is heart rate, respiration rate. So we can easily form a table and we can assign some value to this, right? So that we can come up with a with some score. Okay, if the score is greater than certain threshold, okay, so he may be assigned to this particular category. So in such examples, in such cases, we may go for ML technique. So these are all the typical ML algorithms. You may come across these words: logistic regression, random forest, and support vector machine. These are the examples of ML techniques. The next is DL. So when one can go with this deep learning, so there is a huge difference. There is a difference between ML and DL. In DL, so it has a lot of nodes for extracting the features or the attributes present in our data. So the data may be a signal, or it may be a clinical record, a huge clinical record, or it may be a image, right? So whenever you have a large or high dimensional data set, example, tens of thousands of images or genomic data. So this is actually, it is in the order of GB. Say for example, in case of lung cancer screening, say we have 2000 or 3000 cases. So each case, if you look at the images, it may be around 300 slices per case. So look at the volume of data. So if you have a very high dimensional and large volume of data, you may go for DL. As compared to ML, DL doesn't require this feature extraction. So in deep learning, the feature extraction is done automatically by this deep neural network. Okay, so like our biological neural network, it has our biological neural system has nearly 6-7 millions of neurons, right? So in a much similar way, we can easily mimic our biological neuron. We can easily develop an artificial neuron. So we have number of layers. We can put these neurons in number of layers. Say here input layers, there are some middle layers and output layers. Say thousands of neurons or processing units in each of these layers, and each and every neurons or processing unit in one layer may be connected with another neuron. So we know how the human brain learns things, right? So it is based on Hebbian learning. So we know how to play a particular game, or how to ride a bicycle, and even how to stand and walk, right? So actually how these learnings are taking place in the human brain. So when it is by means of changing the synaptic strength between the neurons. Okay, the neurons are connected through these axons. So by means of altering this synaptic strength, we can learn and remember certain things. Okay, so this artificial neural network exactly mimic this idea. So here, in case of our biological neural network, it is a synaptic strength. Here we call it as weight. So if you show something to the artificial neural network, say I'm showing this, right? The same thing, right? So this mouse to the model, okay? And I say this is a mouse, and I'm showing some other thing, right? So this is a calculator. I'm showing this image, and and this is labeled as calculator. So similarly, I have number of such images. Say in case of calculator, I have thousands of images or 10,000 of images. So 10,000 varieties of mouse images I have. So each of these images, when I show this image, so it is come along with this data. Okay, so the expected output is, so if I show this particular object, what is the expected output? Say, let us consider a binary case, mouse or not a mouse. Okay, so this is a mouse and this is not a mouse. So this may be assigned with 1 and this may be assigned with 0. Okay, so I'm dosing this particular object, showing this particular object, and the expected output is 1. This is a mouse, right? I expect it is a 1. Okay, so similarly, I'm computing the response of this net. So there is something called that is aggregating and applying the activation function. Okay, so by that is tracing back, that is back propagating, we can easily find the error, right? That is they call it as a loss function. Okay, so we have to see each of this iteration or each of this training, we have to reduce this loss. Okay, we have to reduce this loss. It means that, so if I show this particular object to the model, the expected output is the ground truth, right? That is the expected one. This is 1, but the predicted output may be 0. Okay, the predicted output may be 0. So we have to calculate the loss. Okay, and this loss is propagated back to the neural network. Okay, in this case, the weights are adjusted, right? The weights are adjusted. So by means of repeating this for 1,000 times, okay, so each and every time we are updating the weight. After certain time, this loss is gradually decreasing. Okay, so when I saw this particular thing, say I'm coming up with a new object. You may not seen that object before, right? And I show you that object. I say this is a new recipe. Okay, So say some XY recipe. So and the next day I'm coming with the same kind of thing, and I'm showing, say yesterday I have shown one recipe, right? That is a XY. So similarly, I'm doing this for 5-6 days or even week. Then after some time, if I come up with in the next week, if I come up with the same thing, you can easily say this is a particular recipe, right? So this is how learning takes place in DL. So the thing is, it is very important to look at the data, the nature of data, and the amount of data on hand. Then only we can easily choose whether we go with ML or DL. Okay, so the data is limited. If the data is limited and structured, and there is a domain expert available in that particular field. Say in case of medical images, we need the support from the clinician. Okay, so this is the primary requirement while choosing a ML. Okay, and when to choose DL. So if you are working with really large and complex data, so it is very difficult to develop or extract features from the data. Okay, so in that case, we go with DL. So DL requires a large amount of data. Sometimes we can also we can combine both of this, right? So here ML may be used to that is the features are extracted and the ML model may be developed, and there is something called transfer learning in DL. So originally the model is developed for performing some object classification. Say you are learning how to ride a bicycle. Okay, so you know 90% of handling two-wheeler, isn't it? So only thing is there are 10 to 15% variation between riding a bicycle and riding a scooter, isn't it? So this particular model developed for object classification also be used for performing some classification task. The only thing is no need to alter the structure as well as no need to alter the weights already learned by means of training with massive data. The what to do is only we can play with the last two layers or last few layers of the model. Okay, so we can easily retrain the last few layers of the model, and this kind of learning is called transfer learning. Okay, so you can combine this transfer learning of DL with the ML. This kind of technique or model is called the hybrid approach. So nowadays, this kind of techniques performing well or outperforms as compared to the single ML or DL based technique. Okay, and in case of ML, as I mentioned, it is purely depends on the that is the features or attributes associated with that particular radiological image, right? So there are a lot of tools available for extracting these features from the medical images. So still this MATLAB is a very good tool for academic and research purpose. But nowadays, the open source tools are very famous, right? It's becoming or it gaining popularity among the researchers also. So there is a toolbox available in Python called, or there is a package available for Python called RadioMix. That is PyRadioMix, and this particular package contains that is a lot of modules which is used for extracting this radiomic feature. Okay, so this is a general overview of conventional image analysis and interpretation. So in this conventional case, what I mean by conventional is, so we go to extract the features from the given medical data. That is a conventional technique, and we can use some simple linear regression or prediction or classification. We may use support vector machine or RNN, KNN. This kind of classifiers may be used for classification purpose. So this is what I mean conventional approach. In conventional approach, we go to carefully look at those region of interest, probably the tumor region, and in that tumor region, we have to extract some attributes. That is, we have to extract the features, and these features are used for classifying that particular object or particular tumor-like object present in the radiological image, whether it is a tumor or other anatomical structure. If it is a tumor, So what is the stage? Stage 1, stage 2, or and so. Okay, so this is a conventional approach. So here the last stage in this conventional approach is the classification. Right? In this classification system, here ML plays a role. Say, for example, we are extracting features of thousands of cases. Say, in this lung cancer example, say if you include hundreds of cases, so each case may have 130 or 128 slices, and each of these slices may have tens of such bright light structures. So look at the volume of data. So we are also computing, say, 10 to 15 features for each of these objects present in the radiological data. Okay, so it is not possible to develop a rule-based system to classify this cancer or tumor. Okay, so that is where this ML techniques plays a role. So this ML technique, so we have to give this feature vector or feature data as input to the ML system. This ML model predict or classify the system. So this is a tale about the blind physician or ML or machine learning engineer. See, if you look at, say, I hope you know the story began this comic. So if you are look at only a certain portion in the image, or if you are looking at the image with a particular perception, okay, so you may not look at other dimension also. Say, for example, you are classifying the tumor based on only the shape or size. Okay, so it's not a complete one. So we should also consider the intensity as well as the texture, because in medical image, texture plays a vital role. So we have to consider all of these things. Then after careful examination of all of the features, then only you can conclude this is a tumor. Else the story goes like this: by looking at the tail, it may be recognized as a row. Okay, so this is a simple example of mislearning and deep learning. Say you are showing this input, right? And so you have to this image is not directly applied to this ML based model, right? So there is a feature extractor, there is a feature engineer. He has to carefully handcraft the features associated with this particular object, and these attributes are used for training the model, and we can classify this particular object as a car or not a car. Huh? So in case of this deep learning approach, so there is no need for this feature extractor or feature engineer. We can directly show this object to the model. The object learn from the input. Okay, so this is the difference between ML and DL. So now let us back to this features present in the radiological image. It is a study called radiomics. Radio means medical images, and omics means it is a general term related to this study, say genomics, like, right? So radiomics is a radium that is a radiological the features present in the radiological image. Okay, so this radiomics involves extracting many features from this medical images, say from X-ray, CT, or some other modalities, say PET CT or ultrasound image. So this is a general workflow of this radiomic module. So if you look at this general workflow, so we have different imaging modalities, say PET CT, CT, MRI, and the second is feature extraction. Okay, so here feature extractor, say you have to extract the shape, because in case of a tumor, the shape of the tumor is very, very important. If it is a very that is regular shape, okay, then this may be a benign tumor, and the tumor is very irregular. It is not a pure circle. It is something like this. So the shape of the object plays a vital role while classifying the tumor in a radiological image, and also the intensity of this particular structure or object present in the image, and also the texture. Okay, so if I saw something, so if I saw this furniture, you can easily say this is a wooden. So if you look at the floor, this may be a marble floor, or it may be a tile, or it may be a granite floor. Okay, so if you look at the police station, so there is a brick, so it has a definite structure. If you look at the tar road, so it has a texture. Okay, so the texture is a very important attribute or feature used for characterizing or classifying the objects present in the medical image. So there are categories like this. So there are features based on shape, intensity, and texture. So this particular package in Python called PyRadiomix has features or feature extractor for or it covers all these areas, say based features, intensity based features, and also texture based features. Okay. So that is PyRadiomix. It is the name of the module available for extracting radiomic features. So basically, this is an open source Python package used for extracting radiomic features from the medical images. So this supports pre-processing. Say, for example, before extracting the features from the image, we got to improve the quality of the image. Say, for example, the medical data may contain noise. So especially if you look at the ultrasound image of a thyroid gland. So you cannot see or you cannot easily predict whether that particular shape present in that image is thyroid or not, right? So it is highly corrupted, or the image nature itself look like a speckled data. So that is the complexity associated with this ultrasound image. To my knowledge, as compared to other data, that is medical imaging modality like X-ray or CT, this ultrasound image, it is very, very difficult to look at the patterns or the objects or the anatomy of that particular thing. This me?
Please, please mute.
So this pyrodynamics also supports pre-processing like resampling or cropping. So say this tumor may be in a particular location. Okay, I have shown that image, right? That is lung cancer or lung CT image, right? So the tumor is a very small object present in that, right? So processing the entire image is meaningless. So we have to look at only that particular region of interest. It is called ROI, region of interest. So we have to crop that region based on certain characteristics, right? So this supports pre-processing like resampling and cropping. So it's also you can use this simple ITK tool along with this, or it supports the simple ITK. Okay, so you can load the data and you can easily convert this image into NumPy array for calculating multiple feature classes. So it has rich optional filters. Say if you want to reduce the noise, or if you want to extract certain curves or lines oriented at a particular degree or particular orientation. Say there are some curves or lines oriented along this 45 degree, minus 45 degree, or vertical horizontal direction. So it has a derivative filters. Or if you want to smoothen that, so it has also has averaging filter. And if you are particular about noise reduction, it also supports a variety of averaging filters as well as order statistic filter like median filter, midpoint filter. Okay, so this supports all these kind of filters.
Hello, sir.
Yes, ma'am.
Just I want to ask regarding that there is a Python open source package available for RadioMix. Similar, is it available for EEG signal?
What, ma'am? ECG.
EEG, electroencephalogram.
Yeah.
EEG.
EEG. Okay, ma'am. See, actually, this is for medical imaging, not for one-dimensional signals like EEG.
Okay,
But
okay.
you can do one thing. So you can use, see, basically this is implemented in a modular fashion. So most of you participants are computer science background, right? So if you want to develop a code or develop some modules or program for particular application, right? So this is centered around one important thing, right? So this particular pyrodynamics module is centered around this feature extractor module. There are some other modules which supports other thing, right? There may be some image pre-processing and post-processing and gives output. Okay, so you can use each of these module for extracting these features. So originally these features may be intended for images, but you can use these sub-modules for your purpose, for extracting features from your EEG signal.
Yes, sir. Thank you. But just you have shown one workflow, ki pre-processing, feature extraction. Then for medical imaging system, is there any specific method ki baba you need to use ANOVA or PCA for feature extraction, or for filtering we are going to use bandpass filter or any other for specifically medical imaging only?
See, medical images, it comes with a DICOM image, DICOM format, isn't it? So I have shown on this particular tool. So this particular tool easily handle this DICOM image. So I have loaded that particular thing, right? Image sequence. Actually, this is in DICOM format. So see, this lung image dataset is called, the name of the database is LIDC database. It stands for Lung Image Dataset Consortium. Okay, so basically this is in a DICOM format. Okay, see, if you look at the images, so the original image format is a DICOM format. Okay, so if you are very particular about the intensity features, because this DICOM supports a very dynamic, very high dynamic range image. But once you convert this DICOM image into some other image format, okay, so we lose this high dynamic range, isn't it? So, and you are extracting some shape-based features. You are looking at the shape of the tumor, and you are looking at the area of the tumor. So in such case, you can convert this DICOM image into another image, say any other image format, say PNG or GIF, to that format. Okay, so depends on the requirement, or based on the situation, you have to carefully handle the data, right? Without losing the information present. Say, in case of state-based feature analysis, my intention is I want to look at the shape of the object, shape of the tumor, as well as the size. Without losing this, we can play with that. But in case of intensity-based features, if you convert this DICOM image into a PNG image format, basically this is it is a good thing. But if you convert this DCM, that is DICOM image format, to PNG, we lose this dynamic range. So if it is, you are converting this image into an 8-bit, so it is 0 to 255. So the number of intensities are limited to only 256. But this supports a maximum of 65,536 intensities. Okay, so depends on the situation. We can.
Sorry for interruptions. Another participant is also raised her hand, Ashwati. Ashwati, do you have any questions? Please ask. I think no. Okay. So I think one message is coming in the chat box that we are having mask images. How can we create mask images? What are the different ways to create mask?
Yeah, I will show one case study or example of creating a mask. Say, let us consider this image. Okay, so this is a particular slice in a original lung CT image. Actually, this is a CT image, right? So for a particular case, we have nearly 130 such slices. So let us consider this particular slice, and I will tell you how to create a mask for this. Say I am interested in processing this lung parenchyma, right? So this is a lung region. So this is a right lung, and this is a left lung of an axial CT, right? And I want to segment this lung parenchyma alone. So I'm not interested in any other anatomical part. Okay, so I want to segment only this lung parenchyma, only this lung field. Okay, see, here the segmentation or creating mask is based on similarity based approach or dissimilarity based approach. See, if you look at the intensities present inside this lung field, actually it is filled with fluid or air. So in the CT image, it is shown as a very dark image. But if you look at the other part of the image, it is also dark. Okay, it is also dark. So here it is a gray matter. So gray intensities. Okay, and if you look at this region, it is a white, and there are some white spot inside this lung parenchyma. So a single technique will not perfectly segment or create mask. Okay, so we got to apply a number of steps. Okay, say for example, first I will show you this approach step by step. See, if you look at this, this is the original image. Okay, so I'm applying thresholding based technique with some threshold. So I can get this image. So here, see, if you look at this, so this is one object, but there are a lot of holes inside this. So I can fill these holes. So I'm applying the next step. I'm filling this hole. Okay, then I'm looking at the smaller objects. If there are smaller objects present inside the lung field, I'm also neglecting it. So I can get the next mask. Similarly, I can get this one, okay, this mask. So after a series of steps, I can come up with this particular mask, okay. So after that, if you multiply this with the original image, this one, okay, if you multiply, so here this region is labeled 1, other regions are 0. So if you multiply that particular mask with this original image, you can easily get this lung field, isn't it? So see, instead of looking for the lung nodules or bright like round structure in the entire CT image, first we have to restrict our search to this particular lung field. Okay, so here looking for lung nodule is very easy, but if you look at the entire image, it is time consuming and also is that mislead our algorithm or our approach. Okay, so this is how one can create a mask. I will load some other image so that you can know how these things are happening or creating how to create a mask. So this is a small piece of code developed in MATLAB. So if you run this, it will take you to load the image. So you can choose any lung image. Say I am choosing this particular one. Okay. So you can choose any image. So the algorithm runs like this. First, it applies thresholding, then it looks for small holes present inside based on hole filling. It fills the holes inside it. Okay. Then finally, it come up with this mask. Then if you multiply that mask with the original image, okay, so we can extract the region. Then after that, we have to look for small round-like structures present in it. Okay. So here I have looked at the shape of the objects present inside the lung field. Okay, see, look at the series of steps here. So this is the original image, thresholded image. Then after hole filling, I can create this particular mask. Then I am multiplying this with the original image so that I can get this lung field alone. This is a segmented lung field. Then again, I'm applying thresholding so that I can get the objects present inside the lung field. Okay, then after that, I have to see, look at this. There are hundreds of objects in this state. So there are smaller objects. So we know the size of the nodule is about some standard value. So this is about a few millimeter in diameter, right? So we can, by means of looking at this particular feature, so we can avoid all these smaller structures. Okay. Okay, and
Please
so
mute.
finally, if you look at the shape characteristics, okay, we can easily that is encircle or that is we can easily mark this lung nodule. Okay, so here I have considered some basic shape-based features as well as intensity-based features. So in MATLAB, there is a built-in function available for handling this, right? So, but this particular function in MATLAB, region probes, supports only very fewer radiodynamic features like this, right? So if you look at the features available in this biradiomics, let me skip these few introductory slides, and if you go to that feature, okay, see, these are the features supported by this biradiomics toolbox or pyrodynamics module available for Python. So first order statistical feature, there are 19 first order statistical features, then two-dimensional and three-dimensional state-based feature, 10 and 16. Then there are many texture features based on gray level co-occurrence matrix, gray level run length matrix. So the participants may come across this word GLCM computation. Okay, and based on this GLCM matrix, we can extract the features. Okay, so actually in MATLAB, those features that used for classifying the tumor from other non-tumor objects, I used this GLCM based approach. Okay, so this has that is a rich set of features covering all the three areas. That is shape page features, size phase features, as well as texture features. Okay. See, if you look at the first order texture features, these are all the 19 texture features supported by this package, and it also supports 2D, 3D shape-based features. Okay, so if you are working with the volumetric data here, the pixels are called voxels. Okay, so along with this size of the pixels, that is height and width of the pixels, we should also consider the depth, isn't it? Okay, so it's also support this three-dimensional shape features, and this is a simple example of GLCM matrix. I hope the participants may aware of this. So this is a simple image batch. Let us consider for the sake of simplicity, it has only three distinct intensities, say 0, 1, and 2. So this is a darker region is a 0, 1, and 2. So this is the intensity represented, the same image, but instead of this thing, it is represented in its corresponding intensity. Say this correspond to 0, 1, and 2. Okay, so this gray level co-occurrence matrix is plotted like this. So here the intensity is ranging from 0, 1, 2. So along this horizontal and vertical direction, we're going to take this 0, 1, 2, 0, 1, 2, and it checks for the occurrence of this particular pattern present in the image. So how many times? So if you traverse from left to right and top to bottom, how many times the image having this particular pair 0, 1? So if it is a 0, 1, see this is a neighboring pixel having this particular pattern 0, 1. So again, we got to look at this, right? 0, 1. See in this direction 0, 1. Okay, so let us look for this 0, 0 first, right? So 0, 0 here 1, 0, 0, another 2, 0, 0 here 0, 0, right? And see here along this direction 1, 0, 0, you go to 0, 0, right? So similarly, it contains other patterns also 0, 1, 0, 2, right? Similarly 1, 0, 1, 1, 1, 2. So we have to look for these patterns and the frequency of occurrence of this particular pattern. Okay, so here we should also restrict whether we have to look at this pattern along this vertical direction or along this horizontal direction or along this particular diagonal direction. So by means of setting all these parameters, we can come up with this matrix. It is called the GLCM matrix. So if you count all these things, this is 10, 13, 15, 18. So if you put 4 by 18, so this is the probability of occurrence of this particular pattern 0, 0 in our image. It is about 0.22. So sum of all the probabilities of this GLCM matrix results 1. So from this, we can extract the texture features. Similarly, there are other matrix-based approach called gray level size zone matrix, gray level run length matrix, and the neighboring gray tone difference matrix. So these are all the approaches used for extracting the texture features. And if you are very particular or interested in installing this particular open source module or open source Python module for radiodynamic feature extraction, you please refer to this site. So this is the official website of this open source tool, pyrodynamics.readthedoc.io. Simply Google pyrodynamics, that will take you to this link. So here you can download and you can easily see the installation instruction. Okay, so here you can find all the details. So if you use the Python package installer pip, or you are working with Conda, say in this anaconda distribution, you can also use this that is installed via this conda installer. Okay, so you can easily go through this, and if you find any difficulty in installing, I will give you my email ID. You can feel free to contact me. I will guide you, help you in installing and working with this particular open source tool for radiamic feature extraction. Then now let us jump into the case studies, both for ML based, that is AI technique, and DL based technique. So for ML based technique, I am considering this thyroid nodule classification. Why I have chosen this thyroid nodule classification for ML? As I mentioned in the presentation, this ML, while choosing ML, you got to be very clear with the volume of data. Okay, so this particular thyroid nodule data set contains only 100 images. It's roughly 1 or 2 images. But if you choose a DL based technique, even after applying augmentation technique, one can easily multiply the data. Say, for example, you are flipping the data, rotating the data, sharing, right? You are simply modifying the data. So if you apply 10 such kind of transformation, so this 100 data may be multiplied to 1000. But this is not enough for DL based technique. That is why I have chosen this ML technique for lung nodule classification. Okay, so this is the workflow of this ML based lung nodule classification system. Okay, so this is a thyroid nodule imaging. So we have to pre-process the image. So we have to look at, so first thing is we have to refine our search. Okay, we have to identify our region of interest. So this encircled region is the thyroid nodule. Okay, so this is the thyroid nodule. So we have to segment the thyroid nodule, then we have to process with the rest of the steps. So you can find dozens of features, and you should also look at the predominant features which actually helpful in classifying the object as a thyroid nodule or a non-nodule. If it is a nodule, what are the other features used for staging classification? Say there is a classification system, especially for thyroid, is called TRIRAD. So this is a staging system that is internationally acceptable staging system. So if you want to communicate about the disease stage between the physician, okay, so there is a standard, okay, that is called a TRIRAD. So here we used this dual tree complex wavelet transform before applying this GLCM. So one can directly apply this GLCM matrix, or you can also convert your image into, or you can apply some transform to the image, and you should label that image after the transform, after applying certain transform, say wavelet transform or simple Fourier transform. So the coefficients, it shows a very large variations. It's not like your normal intensity. So intensity, if it is a 8-bit image, it has only 256 distinct intensities starting from 0 to 255. But if you look at the coefficients, okay, so it has a very large variations. So we have to convert these coefficients into minimum number of coefficients, or we go to restrict this data. Okay, then you can apply this GLCM calculation, much similar to this applying this GLCM to the raw image. Then you can extract some of these high level features, say contrast, correlation, homogeneity, energy. And by looking at these features carefully, you can also come up with a new metric or new feature. It may be a combination of this basic mathematical calculation, and this single feature may be used to classify whether this is a nodule or lung nodule. So a similar kind of feature is developed. We call it as a thyroid malignancy index. Okay, if this index is greater than 1 or 1.2, so definitely this is a lung nodule. Okay, so you can coin new such words or new such marker, biomarker, okay, by means of carefully analyzing these features. Okay, so you got to consider the most predominant features which is actually used for helpful for classifying the nodule. Then you have to take those things and by means of some mathematical manipulation, so you may divide one feature from another, or you may give more importance to the particular feature as compared to or the weighted averaging. Okay, so by means of doing such things, you can come up with a biomarker which actually used to classify this nodule. Okay, so this is a simple example of ML based technique. And another one is, so this is the result, classification result based on this idea. So this proposed work, okay. So here we achieved accuracy of 99% and the sensitivity is about 100% sensitivity and the specificity is 0.97 or 97.6 and area under the curve is 0.99. Okay, as compared to other techniques, this particular approach performs well. And another case study or example of this DL-based technique is COVID classification. From the lung image, CT image, we got to classify whether there is a COVID virus or pneumonia kind of thing present in the CT image or not. So here we have used three different that is a network originally developed for object classification or some other purpose. Say we have considered dense net, inception V3 and the mobile net, and we have trained these networks individually with equal amount of data, and the response of these nets are taken and it is aggregated. Say for example, if I show some image to these three nets, two of this network may predict it as non-COVID and one may predict it as a COVID, then we have to take the majority. So the two is voting for, so this is a voting based system. Okay, so along with this DL based approach, we can also combine the feature extracted from the ML technique, and on the last stage, we can combine the output of ML as well as DL. The approach is called hybrid approach. Okay, and this is the result obtained from this fused model. That is the voting based approach. We have considered three different models, and the performance of these models were compared to improve the overall performance of this model. But if you include more such model, it increases the complexity of our task. So this is generally not advisable. But in some cases, if you want to increase the performance of the overall system, you may consider the best performing network or best performing model, and you may combine the performance of these models to get the overall response. Okay. So with this, let me wind up the session. And if you have any doubt in my presentation.
Yes, sir. I think the two questions from the chat box. One is Professor Vivek is asking like some existing tools like Level Studio, how authenticate these masks are. He's asking about the mask and the tool called Level Studio, how authentic these masks are.
See here, the mask is, see, once you create a mask, right, you should compare it with the mask created by the expert in that field. That is what we say, this is a gold standard or the labeled data. So if you want to assess the performance of a segmentation algorithm or segmentation model, say especially for image segmentation, mostly we use the UNet model for image segmentation. And if you want to assess the performance of this unit-based segmentation or this simple segmentation technique, we got to compare this mask with the mask created by the expert radiologist. Okay, so we got to look at how many pixels are coincident. Okay, how many pixels in the mask created by the radiologist and the mask created by the system or the model are coinciding, and how many pixels are lying inside are not common in both. Okay, so there is a score or metrics called dissimilarity matrix. So we have to find the dissimilarity matrix of this particular technique. So this is how one can assess the performance of a segmentation model. It's whatever may be the model. It may be a tool or it may be a model or system proposed by you. So only thing is we have to compare it with the segmentation mask created by the expert in that field. That is how one can evaluate the model. And once you confirm your model is or your system is performing better or segmenting better, you can put it in the action.
Yes, sir. One more question is, can radiomic features be used in training deep learning model?
Sir, your voice is very feeble. Can you please repeat the question?
Can radiomic features be used in training deep learning model?
No, the basic approach is entirely different. See, the radiomic features are intended for ML-based technique because in DL, if you look at this particular slide in my presentation, see, look at this particular slide. In case of a machine learning, the machine learning leads, it requires feature extraction step. But deep learning does not require feature extraction, isn't it? So you are showing the object and the object is labeled as car. Okay. So the deep learning model, so this model itself acts as a feature extractor as well as classifier. And in machine learning, this is simply a classifier. So we have to extract the features. Okay, we have to extract the features, but in deep learning, no need to extract any features. The feature extraction as well as classification can be done by the model.
Okay.
And if you want to combine the machine learning and deep learning, so the features that you extracted from this ML technique and the feature extracted by the DL model. Okay, so you can tap somewhere here in the just before the last layer. Okay, so mostly these are all, if you look at the tap the output at this layer, mostly this is a high level features. Okay, so you can take these features as well as the feature from the ML technique, then you can combine this along with the demographic detail like patient age, sex, and all these things, the geography, and some other details. You can combine all these things, then you can come up with a hybrid model. That is possible. But in case of a deep learning, no need to extract features.
Yes, sir, the exact answer. Yeah. Thank you, sir. Once again, on behalf of KMEA Engineering College and behalf of the ATAL FDP program, I thank Dr. Gopalakrishnan for your wonderful speech regarding the medical imaging aspects and AI applications. Especially, you started with the pyrodiomics and how we access the toolbox from the internet, and each library is NumPy, is Python, so you explained. And I noticed that some MATLAB code you shared and you run the segmentation images. Those results are also, so it's a sequentially coming. First the segment, the whole thing, then nodules, and use the whole filling. So it's a series of, it's a bunch of sequential image processing techniques, I thought. So those examples are, it's like it's a different thing. It's a good thing to, like the computer scientist or the engineering background faculties who are involved in this kind of image processing and artificial intelligence. And you are club both the artificial intelligence and image processing, as well as you also showed in last 20-30 minutes, you are explaining the case studies. So that is also provide a conclusive idea about the whole picture, how the system is working with the AI and deep learning, and also in cooperation with the medical imaging field. Finally, the answer session, like how we can get the gold standard. The expert or the radiologist is the basic or the master in that. So based on that gold standard only, we can we can move further, or those gold standard is we considered as the base of any medical imaging related research. Yeah, thank you all the participants, and thank you once again, sir, for the wonderful talk. And related to participants, please fill the session 1, session 2, or all session feedback form as per the particular sessions. And remember, 80% attendance is mandatory for this ATAL FTP. So please cooperate with us, and we will see you tomorrow at 6 p.m. Thank you all.
Thank you very much, Dr. Rafiq, for giving me the opportunity. And I also thank my management, principal, and my head of the department for providing all the resources for conducting research here in PG Tech. I thank all the participants for their patient listening. And participants, if you have any doubt and if you want to collaborate with any project, and if you want guidance, you feel free to send email to this address sgk.dma@pgtech.ac.in. Thank you all. Thank you. Thank you, sir.
Thank you. Thank you, sir. Thank you all. Good night. See you.